50 when we recorded history. This slide keeps coming up. Since 1850, the age of menopause has not changed. The problem is that in Suffolk County, we're the only show in town. We are the only program for menopausal ladies. The average age of menopause is around 51 to 52 years of age. If you become menopausal before age 45, you have an early menopause. If you become menopausal after age 54, you have a late menopause. And if you have a menopause before age 40, you'll have a premature menopause. You can also become menopausal if we operate on you and we remove your ovaries, or if we radiate your ovaries, or if we give you chemotherapy. Now, the problem with an early menopause is the early loss of fertility. More severe symptoms of hot flashes, night sweats, vaginal dryness, painful intercourse, and it puts you at risk for cardiovascular disease and for osteoporosis. Now, women go through 3 stages in your life. From 14 to about 42, 43, you go through the reproductive stage in which your ovary ovulates every month. It produces female hormones and you become pregnant. Around age 45, 46 to 51, you go through the late menopausal transition or the perimenopause, in which you can start having fluctuations in the production of estrogen, and you may develop hot flashes, night sweats, and you may skip 2, 3, 4 months of your menses. This is a picture of the ovary in a woman in the reproductive stage of her life. Those round circles are called follicles. They have eggs in them. And when an egg is released, if you have intercourse, you can fertilize that egg and become pregnant. And these follicles are making female hormone. In menopause, your ovaries make no more follicles, so they make no hormones. They don't make estrogen. Now, when your ovaries in the reproductive stage of your life make hormones, this hormone is disseminated in your bloodstream all over your body. And where you have estrogen receptors, the estrogen hooks up to the estrogen receptor. And you have estrogen receptors in your brain, in your heart, in your blood vessels, in your bones, in your ligaments, in your vagina, in the tube you pass your urine from, in your bladder. Once they get into your cell, and we have 40 trillion cells in our body, if there's an estrogen receptor there, they hook up and turn on a gene, and that gives an action. And some of the actions are, here's a young lady in the reproductive stage of her life. In your brain, you have a center of learning. It increases blood flow to this center. Estrogen also in your brain works on a center that controls our internal body temperature. In your heart, it decreases coronary artery calcium. In your blood vessels, it causes your blood vessels to dilate so you don't develop high blood pressure. In your bones, it builds brand new bones. In your liver, it lowers your cholesterol. In your pancreas, it increases your insulin. In your body shape, it makes you deposit fat on your hips and buttocks. And those are the areas where estrogen works in a woman when she's in the reproductive stage of her life. We know this from clinical studies, that if we remove the ovaries in a woman before menopause, we increase all causes of mortality. We increase cardiovascular disease. We increase type 2 diabetes. We increase osteoporosis and fractures. So it's important that women who have their ovaries removed at a young age, especially those ladies you've all heard about genetic testing who test positive for the BRCA genes, they must be placed on hormone therapy. I showed you a picture of an ovary in the reproductive stage. This is a picture of an ovary in menopause. It is the size of an almond. You don't see any follicles. It's not producing estrogen any longer. Now, how do we confirm the diagnosis of menopause? When you come into our practice, we take your history. You're usually somewhere between 50, 51, 52, 53, and you say, my last period was more than a year ago or more than a year ago. Sometimes when we're not sure, we can do a blood test. The early symptoms of menopause that you ladies will face are hot flashes. Night sweats are hot flashes that occur at night, and more than 90% of you in your 70s and 80s will all develop the genitourinary syndrome of menopause. What that is symptoms and anatomical changes that will occur to the outside of your vagina, to the inside of your vagina, to the tube you pass your urine from, and to your bladder. I need to take a sip of tea. I'm losing my voice. Now, what are vasomotor symptoms? What are hot flashes? It's this sudden sensation of heat in your upper chest, neck, and face. It's a way of your body getting rid of your body heat. So what does it do? It dilates, it lets all your blood vessels, your skin vessels dilate to get rid of this heat. And if you check your skin temperature, it increase 1 to 7 degrees centigrade, and it can be associated with sweating and palpitations. Now, we know this. If you're in the perimenopause, 80% of you will have hot flashes and night sweats. 80% of menopausal women have it, and they can last 7 to 10 years. If you're a Black American, it can last 10 years. If you're Hispanic, 9 years, white Americans, 6.5 to 7 years, and Asians, 5 years. Here's this famous picture when I lecture in the medical school. This is a woman that's saying, many of you have had this. Is it hot in here or is it me? These hot flashes can affect your sleep, your mood, because you don't sleep. The next day you can't concentrate. Women say, I have brain fog. It can affect your work. It can affect your sexual activities. And these hot flashes can be a biomarker in the future of vascular disease and osteoporosis. Now, they're divided in various types. They can be mild, where a patient will come in and say, I get an occasional sensation of feeling warm, or they can be moderate, this sensation of heat and sweating, but she can still do her daily activities, and severe with this sensation of heat, and she cannot do any daily activities. In the 70s, we found in medicine and with research that we all have in our brain a center and a part of our brain called the hypothalamus. It's called the thermoneutral zone. And the thermoneutral zone has 2 zones, an upper zone and a lower zone. When our internal body temperature goes above the upper zone, our brain says, it's hot in here. Let's get rid of the heat. So what does it do? It makes our peripheral blood vessels in our skin dilate. We get a redness of our face and chest, and we perspire. If the temperature goes below the zone, we shiver to raise our body temperature. Now, in menopause, the zone narrows, and I was taught, we were all taught, it was due to the fact that in menopause there was no estrogen, and it was estrogen that caused the widening of the thermoneutral zone. But through recent research over the past few years, we changed that theory. Now we know it has to do with these nerve cells called the KNDY neurons that secrete a substance that narrows the thermoneutral zone. And the reason why young women don't get hot flashes and night sweats is because estrogen puts these neurons to sleep. That's how estrogen works. It works secondly on these KNDY neurons. So when they presented this at my national meeting in 2018, we all said, we menopausal clinicians said, wouldn't it be wonderful if they could make a drug that antagonizes these KNDY neurons rather than hormones? And I'm going to present that today. We have wonderful news. There is now a new drug for that. Now, if you have mild hot flashes, by changing your lifestyle, you can deal with them by adjust the light in the room, lower your temperature, avoid heavy meals in the evening, avoid alcohol, caffeine, nicotine throughout the day, exercise daily, but not close to bedtime, and use the bedroom only for sleep and sexual activities. Another thing that you can do that's not a medication, I did it when I did yoga, is pace, close your eyes, pace abdominal breathing in a dark, quiet room. Some women go to a health food store and they try black cohosh, although there are no medical clinical studies that says it works, but in some women it does. The only drugs that are approved by the Federal Drug Administration are paroxetine, which is a low-dose Paxil, 7.5 milligrams, and the drug name is called Brisdel. But the only problem with the Brisdel is when they compared it to a sugar pill and they looked at daily hot flashes, it only reduced the hot flashes 1.5 times, 1.5 hot flashes to 2 hot flashes a day when compared to a sugar pill. But now we have approved, after waiting since 2018, fezolinetant, this drug that antagonizes the KNDY neurons and puts them to sleep. It's a non-hormonal, it's a safe drug to use, and it's called Veozah. Remember that, Veozah. The gold standard for hormonal therapy is hormonal therapy. We doctors have been using hormonal therapy since the late 1800s. And what doctors did in the late 1880s, they would take cow's ovaries, grind them up, and make a pill called ovulin, and women would take that. In 1942, came out on the market Premarin. In 1966, a Dr. Wilson wrote a book, Feminine Forever, and he said that menopause is a disease. If you wanted to stay young psychologically and physically, you have to take estrogen. But then when I went into practice, we were finding women who had a uterus on estrogen, they were developing endometrial cancer. So what we did is we added progesterone. Now, my society, the North American Menopause Society, tells me to tell you, we only treat women who have moderate to severe hot flashes, night sweats that affects the quality of her life. By that, I mean you can't function with them. And you must be under age 60. We don't give it to 60-year-olds or 65-year-olds. 2, you must be within 10 years of menopause, and you must have no contraindication. The contraindications would be if you had a heart attack, or if you had a stroke, a clot in your leg, if you had breast cancer. In those cases, it would be contraindicated. And it can be done, we give it orally or transdermally. I prefer, in our practice, we use transdermal patches. Why? Because when you take estrogen by the mouth, it goes to your stomach and your liver. It increases clotting factors that can cause a clot in your leg, which can break away and cause a pulmonary embolism or a stroke. So in our practice, we prefer patches, and I also like patches because there are multiple doses from the very, very low to the very, very high. With pills, there are not very, very low doses. The side effects of hormone therapy in the average patient, if you use too much, you can get breast tenderness, so bleeding. That's why I like the patch. We can start off at a very, very, very low dose. And if you have a uterus, you must take with it bioidentical progesterone. And that's what we use in our practice. Now, what are the concerns about estrogen and progesterone therapy? Well, the company that made Premarin many years ago did the Women's Healthcare Initiative, only clinical study on hormonal therapy. And there were 160,000 women, 28,000 of them were on the hormonal part. And what we thought, and it was a primary prevention study, was that hormone therapy would prevent heart disease. And it was supposed to be a 10-year study for those women who had a uterus. There were 16,000. 8,000 got the hormone, 8,000 got the sugar pill. Each patient didn't know which pill they were getting, neither did the doctors, and it was done in multi-centers. The other group of women had a hysterectomy, and they were put on hormones. The only problem with this study is, one, if you had hot flashes, you were excluded. They wouldn't put you in the study. And only 34% of the women from 50 to 79 were 50 to 59. Those are the ladies who put on hormonal therapy. The average age was 63. We don't put women 63 years of age on hormonal therapy. And again, we stopped the study. We stopped the study after 5.5 years because there was an increase in breast cancer and an increase in heart disease, but there was a benefit in fractures and colorectal cancer. But when you look at the results, out of 10,000 women, there were 8 more cases of breast cancer. That's less than 1 in 1,000. There were 8 more strokes out of 10,000 women that got the drug. That's less than 1 in 1,000. And there were 7 more heart attacks, less than 1 in 1,000. The sales of Premarin dropped almost 80%. So what does that tell us? Well, if you look at the Women's Healthcare Initiative, that study, at the women who are 50 to 59, and all the studies, medical studies, in 50 to 59, in women without contraindication, hormone therapy is very, very safe. There's no increase in cardiovascular disease, no increase in stroke, There's no increase in breast cancer if you've had a hysterectomy and you're on hormonal therapy. There's no increase in ovarian cancer. There's a decrease in hip fractures, a decrease in colorectal cancer, and there's a decrease in type 2 diabetes. So the average woman who has no contraindication, who has moderate to severe vasomotor symptoms, that is one of the things we can use, bioidentical hormonal therapy. And what bioidentical hormonal therapy it means, it's the same hormones your ovaries made when you were a young woman. But now, I'm happy to say, the FDA approved recently Veoza. You're going to see a lot about this in your ladies' magazines and probably on TV advertisement. It's for moderate to severe vasomotor symptoms. There are also some contraindications to it, and that would be if you have severe renal disease or cirrhosis, and some medications you can't take with the Veoza. And it can sometimes alter your liver enzymes, but it doesn't cause liver damage. And what we would do is we would check a blood test before and every 3 months. And it doesn't act like hormones. It is not a hormone. It acts in your brain on the Kindi neurons. It puts them to sleep so you'll have a wider thermoneutral zone. I'm going to take a sip of tea again, because I'm losing my voice. I'm really sounding like Kennedy. Okay. I had said the hot flashes and night sweats get better. What gets worse is the genitourinary syndrome of menopause. You have, this is a side view, a woman cut down the center. You have estrogen receptors on the outside of your vagina, on the inside of your vagina, on your urethra, the tube you pass your urine from, and in your bladder. The genitourinary syndrome of menopause are symptoms and anatomical changes from lack of estrogen in your external genitalia, vagina, in your bladder and urethra, and sexual symptoms. This is a picture of the anatomy of a woman in the reproductive stage of her life. She has a normal hair distribution. Her labia major have fat pads. Her labia minor are moist and pink. And when you look into the vagina, you see a thickened vagina that is pink. And when the doctor examines that vagina, he finds elasticity and collagen. The vagina is quite elastic. This is a side view showing the uterus on the left on the top, and the line going down would be a thickened lining of the vagina. Now, what are the symptoms, genital symptoms in the genitourinary syndrome of menopause? Many of you ladies complain when you come to my practice. You have itchiness or burning on the outside of your vagina. You have itchiness, dryness, burning on the inside of your vagina, and you may have a yellowish malodorous discharge. The bladder symptoms that you may have from lack of estrogen are urinary urgency. You got that urge to void. Urinary frequency. You may lose urine when you cough and sneeze, and you may get recurrent urinary tract infections, all due to lack of vaginal estrogen. The sexual symptoms are from lack of estrogen. There's no moisture in the vagina. There's no collagen or elastic fibers. The vaginal walls, the opening starts closing, so you'll complain of vaginal dryness and painful sex. This is the external genitalia of a woman in her late 70s or 80s. She's lost her hair distribution. The labia major are flat. They've lost their fat pads, and the labia minor become very thin, atrophic, and they confuse and cover the clitoris. When we put that instrument in that we do a pap test, and it's called a speculum, the introitus, the opening is closing, and the vaginal walls are white and dry, and there's no elasticity or collagen when we examine you. Now, how do we treat this? Well, the first thing that we do is we recommend you use a vaginal moisturizer. In our practice, we use either Luvina or Replens, and you would use it every other night at bedtime. But moisturizers do not bring back the anatomy that you lost. And we recommend that when you have intercourse, that you use a lubricant, both you and your partner. We recommend also regular sexual stimulation that can sometimes bring back some of the capillaries that are around your vagina. We also recommend, if your partner is not able to have intercourse, to use a vibrator. We also use in our practice, if you have stenosis in your vagina, we use vaginal dilators, and we have a program in our practice of pelvic floor muscle exercise therapy with biofeedback. In those patients who don't respond to moisturizers that bring moisture to your vagina, to lubricants when they have intercourse, we use vaginal low-dose estrogen. Vaginal low-dose estrogen brings back the elastic fibers, the collagen, and the blood flow to your vagina, your urethra, where you pass urine from, and your bladder. Remember that. And you use vaginal estrogen in the lower third of your vagina. And it can be a cream, it can be a pill, it can be a suppository, or it can be a ring. Now, many times women who have breast cancer, and I hope some ladies who are watching this have breast cancer. Not that I hope that they have it, but if they have it, that they're watching this. Many oncologists allow us to use vaginal estrogen in the lower third of their vagina because studies have shown in the lower third of your vagina, it's not absorbed into your general circulation. But if you put it in the upper third or upper part of your vagina, it's absorbed into the uterine arteries, and then it goes all over your body, including your breasts. Some oncologists say, no, we can't because Mrs. Smith had breast cancer. But in those cases, we can use DHEA suppositories, and the drug is called Intra-Rosa. That is not a hormone, that's a pre-hormone. This is Intra-Rosa. Okay, I've discussed hot flashes and how we treat it. I got to take another sip. I've discussed the genitourinary syndrome of menopause. Now let's discuss what you should do generally, you ladies out there. One, I post a lot of stuff on my webpage and on my Facebook page. I did one on being overweight and obesity. You must maintain a healthy weight. There are 13 cancers that will affect you if you're obese. The major ones you worry about are breast, uterine, ovarian, colorectal, and pancreatic. You must maintain a healthy weight. Eat a balanced diet. I'm Italian. My wife makes the Mediterranean diet. We have fresh fruits, vegetables, nuts, beans, whole grains, fish, chicken. Limit your red meats and your sugars in your diet. You need to have adequate calcium and vitamin D. The American diet gives us about 600 milligrams of calcium. We need another 300. A milk, 8 ounces, is 300. A yogurt is 300. There you got your 600, or have 3 ounces of cheese. That's 300. If you're lactose intolerant, take a calcium pill. Calcium pills you take with food. They're usually 500 milligrams. Take one of them at lunch, one with dinner, but that's only if you're lactose intolerant, because they cause gas and constipation. Now, to absorb calcium, you need to take vitamin D. If you're over age 50, you should take at least 1,000 of vitamin D3. You can buy it in Stop and Shop. Anywhere you can buy vitamin D. Vitamin D3 is a fat-soluble vitamin. You must take it with fat. I take mine, and my wife takes hers with our dinner meal, regardless of what you're drinking. And you should be exercising. I spin 3 times a week. I lift weights 3 times a week. I try to play tennis once or twice a week. You should do aerobic exercise. Keep moving. Walk at least an hour every day. Use free weights, but no more than 2 to 3 pounds for 20 minutes, Monday, Wednesday, and Friday. And do flexibility. All the libraries offer you Tai Chi or yoga. I'm sure we have it at the Huntington Library. Our last society meeting, were 1,000 doctors that met, menopausal specialists from all over the world in Atlanta, Georgia. The whole theme was tell your patients, keep moving. Now, what about the tests? I just posted, or I'm on my webpage, PAP test. We do PAP tests. PAP tests are two parts of a PAP test. One part of the test is called cytology. We check for abnormal cells. The other part is we check for the HPV virus. When you're 21 to 29, we start at either 21 or 24, and we do it every 3 years, only a cytology. From 30 to 65, we can do cytology every 3 years, or a cytology and HPV titer every 5 years. And then when you're 65, if your PAP tests have always been normal, you can stop them if in the past 10 years you've had 3 negative cytologies, and the last one was in the past 5 years, or if you've done the cytology and HPV, that call that the co-tests, 2 of them in the past 10 years, and your last one was negative in the past 5 years. Secondly, you should get your blood sugar and your lipids and vitamin D checked annually. If you're 50 or older, you should see a gastroenterologist. You're entitled to a colonoscopy. And at age 65, you're entitled to a bone density. Mammograms, it's on my webpage. I did a video on that. We start at age 40, and we do them annually. The American Cancer Society says do them manually until age 54. And if you're at average risk for breast cancer, you can do them every 2 years. In our practice, we do them every year. And most societies say that if at age 74, you're expected to live another 10 years, you can continue doing that. If you have dense breasts in our practice, we do a breast sonogram on you. And that's all I have to say. Takeaway points. Well, let's open up for questions first.
Okay, thank you, Dr. Bonura. If anyone has any questions, you can either unmute yourself and ask, or you can write it in the chat.
Hi, doctor. My name's Lisa. I was wondering, where are you based out of?
I'm sorry, what?
Where do you work out of?
Oh, I'm sorry.
Mhm.
I'm Director of Menopausal Health at St. Catherine's. My office is in the medical office building. I'm in private practice.
Okay. And I know at the beginning of the slides, it had your name.com, but
Yeah,
I was
let me
trying.
go. I'll go to the last page. How's that? Yeah, I
Oh,
post
that's
every
great.
month on Facebook, frankbenuramd.com, and I post on my webpage, frankbenuramd.com. I post something on women's healthcare issue. This month is on pap tests. Last month was on mammograms. The month before that was on prevent urinary tract infection. The month before that was preventing breast cancer. The month before that was preventing ovarian cancer. I post something every month.
Thank you. And do you recommend seeing your local gynecologist for more of a scan than just the annual?
Well, I recommend, it depends what your risk factors are. I don't know what your risk factors are.
Mhm.
In our practice, we do a breast exam every 6 months on patients, especially if you have dense breasts. And we do pelvic sonograms on patients if you're overweight and the doctor cannot feel your ovaries and you're menopausal, they should do a pelvic sonogram on.
Okay,
Uh,
thank you.
good.
Hi,
What
Dr.
age?
Bonura.
Yep.
It's Deirdre Serber. How are you? I have a question about thyroid stimulating hormone screening. Can you just talk about that a
Well,
little?
what we do in our practice, when we order your annual blood tests, these are the blood tests that I order. I order a CBC, a blood sugar, lipids, thyroid stimulating hormone, vitamin B12, and vitamin D level.
Okay. So I get that.
If you're menopausal and you come in for the first visit, we order on, and you haven't had a period in a year, I might order a 17 beta estradiol on you. And I may order an estrone level on you.
Okay. Thank
But
you.
everyone on their annual exam gets a thyroid stimulating test and gets a vitamin B12 and a vitamin D level.
Okay. Thank you.
So I have a question. So if you have dense breasts, do most insurance companies cover a breast sonogram?
Yeah, if you have dense breasts, we order with your mammogram, and your doctor should be able to tell that when he does a breast examination on you. He should do a mammogram and a breast sonogram. Sometimes we may even order a breast MRI on you, especially those women that have had a breast augmentation.
And have the insurance companies covered all those tests?
Yes, they have.
Okay, we have a few questions in the chat. Okay, so Dr. Bonura, would being in perimenopause at age 47 affect a successful pregnancy if you are able to get pregnant? Would it cause any complications for the fetus and for the pregnancy in general?
Number one, okay. The incidence of natural pregnancy in a 47-year-old lady would be around 1 to 2%. It may be 3% if with IVF. Although I delivered a lady in my practice many years ago who was 51. She had a spontaneous, but it's relatively rare. You run the risk also of genetic problems, Down syndrome in a pregnancy in a woman past age 45. You would be considered a very high-risk patient.
Thank you. And we have another question. Can you speak about late onset menopause concerns and risks?
Yeah, that's a very good question. And I always worry about that in my patients. The more estrogen stimulation that you have unopposed with progesterone puts you at risk in a late menopause of endometrial changes of the lining of your uterus. So I would do a sonogram on you, look at your endometrial echo, and may increase your risk for breast cancer. So in a patient like that with a late menopause, I would be following her 17 beta estradiol level. I would follow with transvaginal ultrasounds, and I would make sure she gets an annual mammogram and breast sonogram.
Let's see, we have another question from Janet. I heard the cost of the new hot flash medicine is very high. Will it be covered by insurance? Do you know?
Well, that
or-
we don't know. We don't know, first of all, what the cost is. Secondly, my office practice checked all the local pharmacies. They all know about it, but none of them got it yet. It's still too early for that.
Okay. But just something to look out for sure. Okay, does anybody have any other questions? I'm just double checking the chat. Those are the only questions we had in there. Feel free to, oh, here's one. Could you explain differences in hormonal birth control and hormone therapy?
Yeah, there's a big difference. Birth control pills have higher doses of estrogen than bioidentical hormonal therapy. One has 1 milligram of estrogen, the other has 0.25 milligrams. So we would not use birth control pills for menopausal symptoms. The only person that we would use a birth control pill to control hot flashes is the young woman at age 40 or 41 that either went through a premature menopause or had her ovaries removed or radiated. Those are the women that we would use a higher dose of estrogen with than we could get in a patch.
I had another question. One of your slides indicated, I believe, you would not use hormone therapy with a patient who had fibroids.
Oh, no, that's an old slide. If you had, what fibroid tumors are benign tumors of the uterus? If you have small fibroids and you're menopausal, it should have no effect on the growth of your fibroids. So we would use it. And I do in my practice. Many women, I would say 20% of the women who we do ultrasounds on have fibroids, and some of them are on bioidentical hormonal therapy, but the dose is so low, it has no effect on the fibroid.
And is there any kind of effects between long-term usage of hormonal birth control and then moving into menopause, the effects that any of that might have, or maybe it doesn't
There
have
was
an effect?
recently a study that showed that there was a slight increase if you're on birth control pills for a long period of time. One study that there might be a slight increase in breast cancer, but there would be no effect if you were on birth control pills and you stopped them and then went on bioidentical hormonal therapy in menopause.
Okay, we have a couple of more questions in the chat. What is considered late menopause? I'm 53 and I have not had a period in 6 months. Where am I at on that scale?
Okay. There's a stage before menopause and there's a stage after the reproductive stage. We call that the menopausal transition. So from around 44 to 46, it's early. From 46 to 51, it's the perimenopause. So if you haven't had a period for 6 months, you're perimenopausal. The lady that the best for me to get is a lady who's perimenopausal, who has vasomotor symptoms, hot flashes, night sweats, and insomnia that's affecting the quality of her life. If she has no contraindications, in our practice, we would put her on bioidentical hormonal therapy.
Next question. Do you recommend seeing a menopause specialist in addition to an annual visit to the gynecologist?
See, the problem is this, and I'm sad to say this, and it keeps me awake very night. I'm the only Google menopausal specialists and see which names come up. Unfortunately, there are very few of us. I think your gynecologist should be trained. He should be going to national meetings. He should be reading journals on a daily basis. He should know how to treat women with menopausal symptoms.
Okay, let me see. Are menopause symptoms universal? In other words, does every woman going through menopause suffer from the same symptoms? Is it possible for some to get through menopause with minimal symptoms?
Absolutely. Remember I said 80%, there's 20% of them, they say, no, I didn't really get any hot flashes. But everyone will develop in their 80s and 90s the genitourinary syndrome of menopause. Remember I said 80%, there's 20% that don't get symptoms of hot flashes and night sweats.
That's good to know. Okay, next question. What things can we do without medicines and drugs? Anything naturally that could help?
I take a deep breath. Sometimes when I play tennis, I hope none of my friends with wives are watching. They forget to keep score. I always tell the guys, maybe you should take Premagen or Prevagen, whatever it is. There are no clinical studies that show over-the-counter nutraceuticals work. Remember, there's a placebo effect, meaning I take black cohosh and my hot flashes go away.
Okay.
But we know this, clinical hypnosis works in clinical studies, and cognitive behavior with a psychologist works in clinical studies. What a clinical studies is you take 2,000 women, 1,000 women get the medication or the therapy, and 1,000 do not. And neither know with medication, the doctor nor the patient, but cognitive behavior and clinical hypnosis works. But there's nothing you can get in a health food store that has been proven to stop hot flashes.
Okay, thank you. One last question that I see in the chat. Are more frequent periods with irregularity a perimenopause symptom?
In early perimenopause, your period can be a day early or a day late. The normal interval of a period is 21 to 40 days from day 1 to day 1. If your periods are coming every 2 weeks, you should let your doctor know. And if you're over age 35, they should do a pelvic sonogram on you to find out if you have any uterine pathology.
Okay. Yeah, I don't see any more questions in the chat. Does anyone have any final questions? Hi. I don't.
If
think
there are
we
no
have-
more questions,
Yeah, go ahead.
I've been lecturing for many years. Couple of takeaway points. If you have vasomotor symptoms, hot flashes, night sweats that are affecting your quality of your life, that you're not functioning. If you have no contraindication, hormonal therapy is safe to use, bioidentical. Secondly, we have a new drug on the market. I'm very excited about it, Veoza. Ask your gynecologist about it. If you have the genitourinary syndrome of menopause, Don't be embarrassed to tell your doctor. When you come to our practice, you fill out your sexual activities, the symptoms that you have in the vagina, your urinary symptoms. Open up your mouth, tell your doctor so they can treat you. Lead a healthy life, watch your weight, exercise, eat a healthy diet, and try to be happy
Mhm.
and have a
Thank you.
wonderful lunch.
Thank you, Dr. Bonura.
Very welcome.
Yes, thank you so much for your presentation. I'm going to go ahead and stop the recording now.